So why is statistics important for clinicians? Why should, as clinicians, we know about statistics? Let us take this example. Drug A significantly reduces postpartum hemorrhage. If this is a sentence which is given in your textbook, or if this is a sentence which is given in any research article, do you want to buy this argument directly? Just because it is written in a textbook, or just because it is told to you by a faculty, or it has come out on a research paper, should you buy it? The question is doubt, right? Because this could have been a random chance error. Maybe in a clinical setting that this drug significantly worked in comparison to another clinical setting. You never know how trustworthy it is, right? Because you cannot accept any statement directly without questioning them. You basically have to question them to understand whether or not you believe it. You just cannot nod and move forward. So this is where statistics is going to come in play, because statistics is going to help you decide whether or not this was by chance and whether or not it was actually proven. So it empowers you basically to answer critical question. It empowers you to basically answer those critical questions that you have in mind, whether or not sahi galat, kya sahi tha, kya galat tha, and whether or not to accept it at face value or not. So basically, this statistics is going to somewhere help you to transform yourself from a passive reader to someone who has to become a critical thinker. So this is where statistics come into play. So research is not just about doing statistics, but it's actually being able to understand what the results of a study actually meant. So even if you are an avid researcher or not, irrespective of whether you are going to undertake a research or not, for you to interpret and understand the findings of another paper, at least you should know whether the statistics applied in that paper was right or wrong. And that is what biostatistics will help you to decide if this result was for real or was it of chance, and should this actually change my clinical practice, because it is this particular statistics which is going to decide whether a patient lives or whether a clinician is misled. So if you do not understand the statistical science behind it, you are not going to appreciate reading papers. Okay, so where does the statistics come in your research journey? So having told you very clearly that this particular concept, this particular road to research series that we are having is basically to empower you to conduct your thesis, to successfully enable you to finish one. So in your thesis journey, where is the statistics going to come? It comes right from the time of your research question. So when you decide on your research question, I told you one of the key factors that you would like to do is to go back and study what the other authors have done. Had there been something similar, or were they not something different? So if you have to understand that, you need to read the statistical aspect of it. So if you have to read the result of another person's paper also, you should be understanding the statistics. And primarily, trust me, what statistics you are going to apply in your thesis will also broadly depend on your primary aim and hypothesis. The second is choosing your study design. So while choosing a study design also, you should be able to understand whether or not you are in a position, whether it is feasible for you to apply a particular form of statistics, whether or not your study has confounders. Because if you have confounders, you cannot use regular statistics. You will have to do regression analysis, which we will speak of in subsequent classes. There also it comes. So statistics does not per se start or comes at the end journey. It is the one which is going to anchor your entire research journey, but from a clinical perspective. So statistics is not coming at the end. Statistics will begin right from the time you start your research journey. It will come to you in data collection, because whatever data you're observing, I told you, anything you observe, anything you document is going to become your clinical data. So if you're going to observe something as a data, you should be in a position to ask this question, whether or not I can count this data, whether or not this data is categorizable, whether or not I can make an interpretation from the data. So that whether or not, the moment you ask this whether or not question itself, you are indirectly implying to the kind of statistics that you want to read. Because remember, if you mess up in stats, if you mess up in stats, you are going to come up with a wrong conclusion, and your wrong conclusion will translate as somebody's wrong practice, which should not happen. Ethically and morally, you have to be right. That is what I'm trying to tell you from day one. Last but not the least, your principal statistics of what you will apply in your research journey will depend on the data type that you are going to take. So remember, all your statistics will start with identifying the type of data that you're going to deal with. So the very first question that you ask is, what type of data did I collect? Did I collect a data which I was able to count? Did I collect a data which I will be able to categorize? Have I collected some data which is absolutely important for me to put them into different strata? I already told you, you can classify data based on multiple different parameters. So one such thing is whether you can count it or you cannot count it. So was it qualitative or was it quantitative? So you, that is the very first question that you're going to ask before determining what statistical test should you be applying. The second question that you should be asked is, how is this data distributed? Now we will see what distribution means. And the third question that you have to ask is whether or not the test that you are willing to apply is right for this particular test or not. So these are all the various strata in which you're going to do. So the flow suggestion starts from trying to identify the type of data. So immediately you're going to ask this question, no, based on the type of data, can you average something? Am I able to count something? It is important. For example, I'll give you most important example, the socio-demographic profile of patients that you take. So if you're sitting in an ANCOPD, you're going to come across people of multiple gravida status. Somebody's obstetric score may be G5, somebody might be G1, some can be G7, some can be G11. So can you bring an average for this? So in my 100 patients that I saw today, the average gravida status was so and so. Is that actually going to make any sense? No, you cannot average gravida status. You cannot average a parity status. Right, it makes no sense. Similarly, can you actually try to say, estimate blood loss in a labor room? Yeah, that you can. You can say, of all the 10 patients that I delivered today, the estimated average blood loss seen throughout the day was somewhere around 250 ml or 300 ml. So this particular fact of whether or not you're dealing with something to quantify or not will determine the type of statistical test that you're going to be doing. That is why data is predominantly categorized as qualitative and quantitative. Quantitative means numerical, qualitative means you're putting it into categories. That is why it is otherwise called as categorical. This categorical data is further classified as nominal or non-hierarchical. Hierarchical, for example, your blood types. Blood type is A, B, O. It does that mean O blood group is better than B? B blood group is better than A? Who's superior? Who's inferior? There's no hierarchy. There's no strata. There is no stratification. It's just a random thing. It's just a quality. A type personality, B type personality, C type personality. It is not going to make any sense. So that is why it's called nominal or non-hierarchical data, while the second type of data is ordinal. Ordinal means here hierarchies are involved. The best example is going to be your Bishop scoring. This we discussed in the last class, right? Your Bishop score, though you're giving a number, you're giving someone's cervix status as 6, someone you're giving 5, someone you're giving 3, someone you're giving 8. But does that 6, 5, 3, 8 actually represent number? No. It is just going to say cervix favorable, yes, cervix non-favorable, no. Yes, induce, no, you're going to give some cervical ripening agent. So you're going to stratify this. This is basically categorization. That is why there is some hierarchy involved. Similarly, for example, stage of cancers, CA ovary stage 1, stage 2, stage 3, stage 4. Can you see as the stages are increasing, the hierarchy or the uh, level of affection of these disorders are also increasing. So wherever hierarchies are involved, but absolute numbers are not involved, you call them qualitative type of ordinal data. Then you have quantitative data. They can be continuous data or they can be discrete data. Discrete data, for example, can be blood pressure. Somebody's blood pressure is 120 by 80. Somebody's blood pressure is 90 by 50. Okay. Though we have a range for it, can you actually compare this range? No. Similarly, pulse rate. Somebody's 72, somebody's 80, somebody's 86. It makes no sense. But continuous can be somewhere where you have ranges. For example, you have birth weight of babies 2.5 to 3 kg, less than 2 kg, less than 1.5 kg. So that will determine what type of data that you're trying to deal with. Remember, wherever you are talking of the categorical data, you try to categorize and stratify. Wherever you're talking about quantitative data, you will involve some numbers and present them as frequencies and percentages. Okay, I hope this much is basically clear with you. If this is clear, we will move on with the subsequent slides. Okay, so examples that I told you already. Okay, qualitative data means that you're not describing any numbers, you're just looking at qualities or categories, they cannot be meaningfully averaged. You cannot average these things. Example, no order group nominal is blood group or mode of delivery, and ordinal group is cancer stage, bishop cervix category. While whatever can be counted is your quantitative data, they can be continuous or discrete, and I have given you these examples. And the biggest plus point behind using quantitative data is that you can have arithmetic operations involved in them. You can have arithmetic operations involved in them. So the critical concept behind statistics is that using a wrong statistical test for a wrong data type is a grave error. Okay, it is just like trying to give oxytocin and inducing a patient to placenta previa for her to go and bleed to death. So remember why again and again I'm stressing on what type of data you're dealing with is because on a golden rule, if yours is a qualitative type of categorical data, you will present them as proportions. And if you're using numerical data, you will present them as mean or median. Now, thus lands to another basic question of what is mean, what is median, and what is mode. Okay, this is a very, very important thing which I want you to understand. Mean otherwise stands as average. Okay, for example, if you have 100 patients, okay, from patient number 1 to patient number 100, okay, all of them have delivered. When they are delivering in the labor room, you are doing something called as visual estimation of blood loss. Patient 1 bled 250 ml, patient 2 bled 300 ml, patient C bled 500 ml. So, of all the 100 patients that you have incorporated or included, you can come up with an average number that will tell you that this is how much that commonly in your setup or commonly in Indian women, or since I'm from Nagpur, Nagpurian women are bleeding, and what are the causes for it. So whenever when you're doing a trend analysis and you're able to come to a common number, that average is called median. But can you do the same thing for length of hospital stay? Let us take the same example. In the same study that you are identifying PPH patients, the first thing that you saw was visual estimation of blood loss. Now, the second outcome that you want to study is average duration of stay in the hospital. That is not same, no? It depends on the comorbid status, whether or not the patient had PPH in normal delivery, whether or not the patient had PPH in cesarean section. It depends on a lot of other parameters. For example, one patient normally for normal deliveries we discharge after 48 hours, right? Or 72 hours, 48 hours or 72 hours. For cesarean section, it's 5 day or seventh day, depending on your hospital local protocol. So does that mean 48 hours is same as 7 days? No. Similarly, if it was a bedridden ICU patient, severe preeclampsia, she had an intracranial bleed, you took her for emergency cesarean section, you encountered postpartum hemorrhage, or she developed peripartum cardiomyopathy, she was in the ICU critical care unit for 20, 30 days. You remember when you're having a group, when the average cluster was between 1 to 10, you had some 5 or 6 patients who had 15 days stay, 25 days stay, 28 days stay. In fact, I have had patients in my PG days who stayed for 42 days and then we ended up transferring her to medicine, stating that finally the puerperal period is over, please take her. Can you see they are all confounders or they are potentially outliers? They are not falling under the common group. Whenever you have such potential outliers, that means your average will be wrong. Because what average in statistics actually means is you want to know something which falls in the mid range or something which is most common. Just because you have 142 number and one number, you cannot take the average as 24 to 21 or 21 to 24, because that is not coming into the common era of 1 to 10. So only because of this reason, for certain outcomes where you have a lot of outliers, you use something called median, especially when outliers exist. Example, number of teenage pregnancies or number of elderly pregnancies. They are not common, no. The common number of patients that you are encountering are either going to be in the reproductive age group, somewhere between 20 to 30 is a common age group that you're going to encounter. So this becomes another important point for you to understand where you use mean and where you use median. And the last one is mode. Mode generally transfers to most common. If you're seeing 25 patients of placenta previa, okay, or let us give you fibroid for example. If you're seeing 30 patients of fibroid, you would have seen that hardly 5% of them will actually present to you with heavy menstrual bleeding. The rest of them, it is incidentally found out on ultrasound, because the most common presentation of fibroid itself is being asymptomatic. Incidentally, they did ultrasound for some pain abdomen or for some other cause, and they ended up finding that they have some small fibroid or some small ovarian cyst. So what was the trend? The most common trend, or how many numbers were frequently repeated, that is what is going to translate to you as mode. So you have to understand what mean means, what median means, and what mode means. Okay, remember there are certain other terminologies also, like variance, standard deviation, and range. Okay, this is for higher level of biostatistics. I told you very clearly, my aim here is to make you read a paper very well, understand what they have found out, and help you do a research yourself. Because at the end of the day, as I told you in first class, biostatistics, you can always hire biostatisticians, but you should be able to interpret the results. So I am not going to be taking these things, but these are also important for you to know, at least from a theoretical perspective. So I would recommend that you have separate lectures by Vivek Jain sir on biostatistics in the app. You can go and refer to them. There he is covered in detail about all these things. Okay, so I told you three preliminary questions that you're going to decide before choosing the type of test that you're going to actually be using for your research proposals or for your data sets. The first question was identifying the type of data, and the second one was trying to know how the data was distributed. So what does the term distribution actually mean? This is where we are going to come up with some examples, and you need to understand this. So the basically distribution means a pattern. Pattern of what? Pattern of spread. So if you're studying 100 patients, what is the common pattern across which they come? How many of them tended to come from rural area? How many of them tended to come from urban area? Or for example, if you're seeing PPH patients, what was the HB values that people are getting clustered around? If you see, most common CBC report that you will encounter in an ANC patient in labor is somewhere between 8 to 9.5. Right? This is the most common, which means there is some clustering around this value that you have to understand. So only when you understand that it is clustering around a value, will you actually be able to decide what type of test you should do. That is where it comes to understanding distribution, because distribution basically refers to how a data is arranged in your data subset, how often each value is repeating itself or is frequently occurring on itself. It's basically the spread and the shape of your data. So when we talk of distribution, there are certain principles of distribution. What is the center of distribution? The center of distribution is determined by your mean, median, and mode. Because what center are we trying to study? We want to study the most common also. We want to study the frequently repeated also. We also want to study what is the average. That is where your centrality will come. So you want to study whatever is there in the center. For that, you should know to identify what type of distribution it is. That is, or in other words, if it is all aligning in center, it means that it is in a normal distribution. How wide the data is, what is the minimum value to what is the maximum value that you want to study, then what is the overall shape. So if I were to draw this as a curve, what is the overall shape? Is it bell shaped, or is it skewed to the left, or is it skewed to the right? How is it? Is it uniform in distribution? Is it unimodal, or is it multimodal? These are the things that you should be understanding from what distribution actually means. To make it further easy for you, I will also teach you a trick of how to know whether your data is normally distributed or not. But before that, let us understand what a normal distribution actually means. Normal distribution means there is balance. Okay. Have you actually studied the golden ratio? Okay. The golden ratio. What does golden ratio actually means? That there is balance in nature. Golden ratio basically means that if according to your eyes, or if something looks pleasing to your eyes, it means that there is some inherent balance of nature that is there in it. Okay. Similarly, we are trying to look for such balance in your data sets. If your data set is not balanced, it means it's not equally distributed. It means there are going to be those outliers. It is going to mean that there is some confounder. It means that you need to do some additional tests. You cannot normalize, you cannot generalize your data findings. And this is commonly possible, no? If you have 10 cases of placenta previa, you have one accreta, one increta, or one random percreta, one surgically surprising percreta. Okay, you encounter these surgical clinical surprises quite often. That is why it becomes important to understand whether or not your data set is normally distributed. Because though by nature we love balance, remember a disease always interferes nature's balance. That is why it is important for you as statisticians, as clinicians, as clinical researchers to understand whether or not your data set is normally distributed. So normal distribution means there is clustering of data in the center, which means this mu, I'll zoom it for you. This mu, which means mean, okay? I think it's too dark. Yeah. This mu, which means mean, is also equal to the median, is also equal to your mode, which means all the three measures of central tendency that you call, all the three parameters or statistical indices which measure central tendency is one and the same. That is what you mean by mu. Okay, so mean is equal to median is equal to mode, and if this happens in your data sets, which means your data set is acceptable, it does not have a lot of confounders or outliers, and it is an okay data set, and then you can generalize the findings of these data. So this particular bell shaped curve is called bell curve, and since it was identified by a mathematician Gaussian, it's also called Gaussian curve, or otherwise called as Gaussian type of distribution. Okay, what do you do when your data is not normal? All of a sudden you encounter and or you find out that your data is not normal. Okay, many a times not all data type will follow the bell curve, because many real-time world incidents that we generally see are always clinical and sudden surprises. They are further subdivided into two types. They can either be positively skewed, which means there is more often clustering on your right hand side of the curve, or it is left skewed, which is negatively skewed, because more often that the long tail tends to extend to the left. So if you look at this Gaussian curve, this is the point of reference 0. If you take anything here is negative, anything here is positive, and then these central boxes that you are drawing are your standard deviation. So your normal Gaussian curve will anywhere include between -3 standard deviation to +3 standard deviation. This was a recent MRCOG2 single best answer type of question. So that is again time and again I'm reminding you that statistics is not just for PSM people, it's important for clinicians also. At least if you have to pass your DNB examination and MRCOG2 examinations, because statistics is going to keep coming around in your life. And if tomorrow you march forward to become a guide, if you march forward to become an avid researcher, you should be understanding what basic stats mean. Okay. So, why is it important to understand whether or not your data is normally distributed? I already told you that because only then you will choose the right data set, you will detect whether or not there is some bias, there is some outlier, some anomaly, and you'll be able to make better predictions. Okay, so you will now understand that a quantitative data is there. So first you took that type of data, you asked that question, you divided it into quantitative or qualitative. Now once it's a data type is noted, you will then try to check the distribution, whether it was symmetrically distributed, which means it was normally distributed, or it was skewed, which means it's not normal. Because only based on whether or not your data set was normally distributed or not normally distributed will you actually to be choosing the type of statistical test that you should be doing. But it's easy for you. Do you think it's easy for you to check how normality? No. That comes to a very important question on how to check normality. How to check normality. Remember, these days you have AI. Okay, you have a lot of AI apps. Just upload your data sheet set and it will tell you whether it's normally distributed or not. But in the olden days, what people used to do is they would plot them in Instagram, and if the histogram looked like a bell-shaped curve, then it meant that it was normally distributed. Second is they just calculated the mean and median. If mean and median were almost similar, or when the standard deviations were not too far apart, they understood that okay, this was normally distributed. And the third test that you can do, this is available in softwares like SPSS or Stata, or you will give it to a biostatistician. Okay, it is called Shapiro-Wilk test. Okay, this is an important MCQ question. Shapiro-Wilk's test is an important MCQ question for most of you. What is the name of the test that is actually used to check whether a data set was normally distributed or not normally distributed? And the answer is Shapiro-Wilk's test. I am not going to be telling what each test mean, how each test is to be interpreted, how each test you have to do. That is a part of biostatistics curriculum. I am only going to tell you as a clinician which test to apply, what you should read or infer from results. That's it. Okay. So to check whether your data set was normally distributed or not, you will first plot an histogram, or you can compare the mean versus median, or do a normality testing using the Wilk-Shapiro test. So having decided the type of data, quantitative versus qualitative, then in that quantitative data, whether or not your data set was normally distributed or not normally distributed, the third thing that comes is what test you're going to apply. That comes us to a key concept that there are two types of tests available in biostatistics. They are classified as parametric versus non-parametric test. This is arguably the most important slide for you. It is going to be your take-home slide. Okay, so parametric tests are those tests, and you will apply these tests only when you assume that your data is normally distributed, which means your data set was bell-shaped. If it were not, you will use non-parametric test. So here you will present every data in the form of mean and standard deviation. If you look at research paper, they would have said the average age is 45.2 plus or minus 3.5 standard deviation. That plus or minus 3.5 is anywhere between, if I were to give you a random number, 45 and 3.5, the patient's age group, the most common age group was between 41 to 49. This is what it actually means. This is what it actually translates to. You should be understanding this. While if you are not normally distributed, I told you, if there are outliers, whenever there were outliers, you will not calculate average. You are looking at the common or the repeat. So what do you mean by repeats? It meant median, or you will use your mode. And whenever you use median or mode, I want you to tell you that you cannot be using standard deviation. You will have to present them as ranks. You'll have to present them as ranks. You'll have to present them as hierarchies. This is also very, very important. Okay. Next, remember, parametric tests are always applied where it is more powerful. For example, you're able to detect some true difference in anything. Okay, this we will understand in subsequent slides. And wherever you have a lot of outliers or robust outliers, you will use non-parametric test. An example of parametric test are your t-test, ANOVA test, and Pearson's correlation. While your Spearman correlation, Mann-Whitney U-test, and Kruskal-Wallis test are non-parametric tests. Unfortunately, what these tests are meaning, I'm not going to tell you, because that was too much for me also to understand when I was doing my foundations in clinical research course from Harvard. I'm not going to put up too much of information to you today that you will forget what basics also are there. So I just want you to now remember or by heart probably that these are examples of parametric test and these are examples of non-parametric test. So now we are going to mind map. What we're going to do is something called decision analysis by decision tree approach. Okay. Now that you have a data set, which test should you be applying? Remember, this is important for you while you're doing a thesis. This is important for you that sometimes even if your biostatistician is wrong, because most of you during your thesis, you're going to give some money to a PSM person or to a biostatistician and ask them to analyze your data and give the results back. But have they actually done anything right? How will you know that? For that, you should also be knowing some basic biostats. No, you cannot randomly just copy paste what they have done. So for that, understanding what test you should be doing is important. And how do we do that is based on statistical test selection. How to select test? Basically, you divide them as categorical or numerical data that I told you. So if it was categorical data, the next question that you're going to ask is how many comparator groups do you have? How many comparator groups do you have? Okay, do you have one group? Do you have two groups? Or you have more than two groups? If you have one group or if you have two groups, then you use the test called goodness of fit, which is your chi-square test. You use your chi-square test. Chi-square test is used for qualitative things and whenever you're using one or two comparator groups. Remember, a chi-square test for chi-square test, always you interpret based on a 2 by 2 table. I already told you that these statisticians are very fond of 2 by 2 tables. Okay, they're very fond of 2 by 2 tables. DE plus 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 plus. This is how you're going to present disease versus exposure, or what are the things that you're trying to qualify, what are the things that are trying to see. Whenever any single value, for example, if this is a simple 2 by 2 table, value is 2, 4, 1 and 0. Even if you have one value as 0, do you think you will be able to come up with any data? No, because at the end of the day, anything multiplied by 0 is equal to 0. So your chi-square also will not come as any other specific value. So since you have values less than 5 in any of the expected frequency, each of it is called a frequency. Okay, each dabba is whatever number you're writing is called a frequency. So anywhere where your observational outcome has value of less than 5 or 0, let's keep it 0 for your understanding, you will use a special test called Fisher's exact test. Otherwise it's called Fisher's correction to chi-square. It's otherwise called Fisher's correction to chi-square. This is simple for qualitative data. So whenever you hear the word qualitative, you should only think of chi-square test. Okay. Now, quantitative is where people get absolutely confused because quantitative is where most commonly we use. So again, same rule. Quantitative data, how many comparator groups? Only one group, two group, or more than two group. If there is one group, then you will ask this question of distribution. If it were normally distributed, you will use a one sample t-test. If it was not normally distributed, you will use its equivalent, which was Wilcoxon signed rank test. Okay, remember this much. What each test is, how each test is done, what is the formula of it, that I'm not going to tell you. For that, you should undergo workshop training on Stata, on SPSS. Okay, these were part of my training curriculum. Okay, and they're very difficult to do also. This is basically like coding. Okay, and here everything is binary. It's either 0 or it is 1. That is how these software products work. So I'm not going to confuse you. Just remember, if a data is not normally distributed, you will use Wilcoxon signed rank test. Now, if there are two groups involved as comparators, you're comparing it with two groups. You have normal distribution and non-normal distribution. If it's normal distribution, you will use a paired test or an unpaired test. Now, what do you mean by pairing and unpairing test? Simplest example, if paired data versus unpaired, I'll give you an example. Okay, you have a patient A, you have a patient B. Okay, you are comparing two things in both A and B. Okay, then what you do is unpaired test, because here you're using independent, because A is not dependent on B. No, A is not dependent on B. Obviously, whatever you evaluate in A and B, the outcome of A and B are going to be independent of each other. While at point A, in a patient X, you're evaluating something. At point B, after some 5 years, in the same patient X, you are evaluating the same thing. Here, remember, X is also same, and what you're evaluating is also same, just that the time has changed. And that is where you have to pair their data, because here it becomes dependent. Your result or your statistics will depend on either the X or the parameter, or most importantly, on the timeline that you have followed them up. So that is the simplest difference of where you will use paired test and where you will use unpaired test. Got it? If it were non-normal distribution, there were outliers, there are a lot of confounders, there are a lot of biases in your study, and it is also comparator group, two groups are involved, then you will use Wilcoxon signed rank test or Mann-Whitney U test, depending on not whether they were dependent variables or independent variables. And lastly, whenever more than two groups are involved, but it was normal distribution, you use ANOVA. ANOVA is analysis of variance. Okay, analysis of variance of observations, and if it's a non-normal distribution, you'll use Kruskal-Wallis test. Got it? I know these terms are very, very difficult. Each test has a name, but unfortunately, you will have to remember the way it is only. You cannot, I cannot give you different names or different mnemonics to actually help it. So just remember this mind map. Just try to by heart this mind map. It's going to be easy for you as to what test you're going to take. So at the end of the day, the decision logic that so far you followed was based on only four things. What was the data type? How many groups involved? Whether the distribution was normal or not normal or skewed? And then whether it was a paired data or an unpaired data. These are the four things which are going to help you determine what type of statistical test you're going to use. So some rapid exam tips for your MCQ exams, especially for your MRCOG and for your NEET SS. I want you to remember that whenever they talk about means, mean is given in your question stem and normal distribution is given in your question stem. You have to choose between t-test and ANOVA. So if it was more than two group, you will choose ANOVA. If it was two groups or less than two groups, you use a t-test. Simple. That's all. Simple. Whenever there is a skewed data, you will speak, or whenever in the stem they don't mention mean, but they mention the term median, you will use any of the non-parametric test. Whenever they talk of proportions, you will only talk of chi-square, and if any one frequency variable is less than 5, you will talk of Fisher's. If the same patient is evaluated twice, it is paired. If two different groups of patients are involved, then it is unpaired, or two different patients are involved, then it is unpaired. This is all that I want you to remember for statistical test selection.